The first question, of course, to ask is family violence a problem? And if so, how big a problem? Well, we've got good survey data here from Aotearoa New Zealand. Our 2019 family violence survey showed that for children, adverse childhood experience, or ACE, is common. The important thing here is that this is a predictor, and the more adverse childhood experiences, the higher the risk of intimate partner violence when they're an adult. And that includes experiences that included physical abuse and sexual abuse. Even distribution of adverse childhood experiences between males and females, but sexual abuse much more common amongst women. As a child, that would be 50% of both men and women, or more than 50%, reporting intimate partner violence. A difference in the nature of that violence between them, and this includes physical, emotional, or sexual violence. The latter much more common amongst women than men. The really significant thing here is, of course, and this is why we're interested in it, as healthcare professionals, as those responsible for the health of our population, is it's a strong risk factor for poor health outcomes. And for both men and women, but a much stronger effect amongst women. So is this an important health issue? Is it an important public health issue? Heck yes, and we've got good New Zealand data that shows that. So of course those poor health outcomes are the sort of the near-term things, injuries and the requirement to have those treated. But we're talking here about long-term health outcomes as well, both physical and mental well-being. And some of these mediated through the stress that happens in that intimate partner violence and the relationship situation. And these are not trivial, so we're talking about increased risk of cancers, high risk of cardiovascular disease, and this is based on New Zealand data. So both proximal effects, of course, but also long-term distal effects, and these are not trivial. So intimate partner violence is a quantified and important risk factor for a range of poor health outcomes, both physical and mental. This is a significant health issue, and it's an important part of both diagnosis and management of people presenting to our healthcare system. And the important thing is we've got some New Zealand developed really helpful tools to support clinicians and those working at the front line to do this, to ask questions and then to put in place the sort of supports and response that people require and that we know make a difference in terms of outcomes. Remembering that sometimes a visit to a healthcare facility can actually be part of a person's safety plan. So that interaction is a really important one, and it's important to both identify the presence of intimate partner violence, but also then to respond and put in place those protections. So we've got good guidelines here in New Zealand. Now, these are not necessarily easy questions to ask of people, and we can feel a bit uncomfortable doing it. But let's be honest, as clinicians, we ask kind of quite intimate questions. We're asking people about their sexual and reproductive lives. We're asking them about their consumption of alcohol, even consumption of illicit drugs, because that can be important in terms of diagnosing and management. So we're used to asking challenging, perhaps slightly uncomfortable questions, and there's no reason why we should exclude these ones on that basis. But probably most importantly, we've got evaluation in New Zealand that shows that yes, you can train people, yes, you can make the tools available, but the real kicker, the critical part for whether or not this happens routinely and we identify and therefore are able to support these people is if there's good, strong leadership at a service and an organisational level. So it's critical that leaders, clinical and non-clinical, both create the expectation but also the enabling environment that sees this happening as a routine part of healthcare, that people, both children and adults, are identified and that appropriate support and management happens. There's no doubt that we need to do better on this. We've got survey data that shows that there's variability around the country. One of the critical things about whether or not this is done routinely or more routinely is good organisational leadership, structures, training, resourcing available, and then of course having those referral pathways in place so that clinicians, if they do identify someone, they're able to put them on that pathway. They're able to refer into services that will then assist that person. One of the other reasons we should be just routinising this as part of our practice is it's a part of our broader ethical responsibilities and thinking about what it is that's causing the problems that people are presenting with, and then putting them on a pathway to address those health problems. So if we think about those sort of key ethical principles, this is a key part of ethical clinical practice. There are a lot of pressures in the health system, and our frontline and back office staff are under a lot of pressure. The question, of course, that can be raised is there time to do this? We've got really good guidelines here. We've got training programs to actually support clinicians to develop the skills to do this routinely. So the call to action here is really for leaders at clinical and at service and at organisational level to make this an important part of the organisation's approach to the delivery of care. Just as important as diagnosing any physical or mental condition is identifying and responding to intimate partner violence.